Hello and welcome to today's webinar, Realizing the Potential of Post-Acute Care Partnerships. Before we get started, I'd like to announce a few brief housekeeping details. Today's session is being recorded and an online archive of today's event will be available a few days after the call. You will receive an email from AHIP that will ask if you would like to receive the archive. Please respond to the email if you would. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the Handouts tab. The antitrust statement prohibits us from discussing competitively sensitive information. Please keep in mind that you may ask a question at any time during the presentation by typing your question into the chat box located in the lower left-hand corner of your screen and then click Send. You can adjust the size of the slides to fit your screen by clicking on the Scale button located in the upper right-hand side of your screen. We're very fortunate to have with us today Gary Jacobs. Gary is Executive Vice President of Strategic Relationships at CareCentrix. In that role, he is responsible for accelerating CareCentrix' transition to value-based care through external partnership development. Gary brings more than 25 years of public policy experience with CareCentrix, focused on creating more efficient collaboration between health providers and payers to benefit recipients of Medicare and Medicaid. At this time, I'd like to turn the floor over to our presenter.
Thank you very much, and welcome everybody. Hope we find this to be a interesting discussion and look forward to your questions as well. So what we're going to do during this hour discussion is do an overview of the current market in post-acute care, the opportunity in managing post-acute spend, and looking at the post-acute, a viable post-acute model for value-based care in a rapidly changing world. So we begin with what the market looks like, and we talk about post-acute expenditures a lot, and we read a lot of the literature about what's happening, but when we cut to the chase, the expenditures have gone dramatically up over the last decade or so, and we're now talking about a spend equivalent to over $60 billion based on MedPAC data, and the number of people being discharged to post-acute facilities rapidly increasing in Medicare and Medicaid and the privately insured populations. When you look at the total spend, I think it's quite interesting to look at post-acute in the context of hospital and physician services, which historically have been the big spend items from a health plan perspective. And now we're looking at post-acute being almost half of the hospitalization spend, or almost equalizing to the physician spend, which is an awful lot of dollars. And when you break that category down, we're breaking it into SNFs, home health, inpatient rehab, and LTACs. And when we look at that overall spend number, we're looking at fee-for-service data as supplied by MedPAC in their data book that they provide annually to Congress. And then we looked at episodes of care with the help of a researcher at Brandeis, Rob Mechanic, and we found that in some items like CHF and COPD and renal failure, that a 90-day episode of care, the post-acute spend can approach over 70%, which is a dramatic number in terms of overall dollars being expended for one condition. And the focus of this discussion is also condition-based control of expenses as we move down. So in this slide, we're taking a look at how people have begun to look at dissecting the post-acute spend into the categories we talked about in the previous slide and where they're realizing savings. So when we looked at ACO data provided by Levitt Partners and others, we're able to isolate that where the MSSP savings in ACOs were going back to 2012 is the year that was studied. It looked like a large percentage of how the ACOs hit their MSP savings thresholds was through reduction in nursing home days on a general basis. So I'll just kind of leave that out there for now, and we'll come back as we discuss the entirety of controlling and managing this overall expenditure. So we look at savings in a 90-day episode, factors that you need to be considering in your strategy. And some of the results that have showed are up to 27% reduction through appropriate care transitions management, which is a heavy focus on nurse care managers managing people with the help of analytics and big data to kind of move people through the post-acute system on an episode of care basis, strategically and intelligently. It also reduced hospital readmissions by 35%, which seemed to be the biggest factor in the overall cost of post-acute spend. And from an administrative and unit cost reduction, looking at a number about 10 to 15% savings. So just to give you some sampling benchmarks of what we've been able to identify in 3 categories within a 90-day bundle. And then when we kind of move forward and look at where the largest spend item is, it goes back to the discussion around readmissions. And if you look on the left, you can see that in a 90-day CHF DRG, that look like a lot of acronyms, but in that number, you can see that the biggest expense had to do with the readmission, followed by the overall index stay for the general hospitalization, and then the nursing home cost associated with it, and then the Part B physician costs. So you see how readmissions as a cost driver in the whole post-acute episode is real critical in being able to control that to manage spend. And when you look at all cause readmissions based on, again, post-acute data and the Levitt work, found that in Medicare, the overall fee-for-service number was 17.3%. And you can see Medicaid, privately insured and uninsured. But the Medicare number, potentially by decreasing that, their data presented $26 billion in annualized savings. So it's a real issue to take out of the system is the unnecessary readmission structure. And then we moved into analyzing some data on CJR as a bundled payment program that everybody is pretty much aware of, and there's a lot of data starting to emerge on CJR, so it becomes really relevant in understanding the entirety of post-acute. So in this work, which was commissioned by the Alliance for Home Health Quality and Innovation, by Dobson, Davanzo, and Associates, it looked at the role of home care vis-a-vis facility care in cost in a CJR bundle and through the federally reported data. And you can see that in the readmission rates by facility, by home health, and overall, what the numbers look like, which generally favored home health. And then when you broke it down into one particular type of joint replacement strategy, you look at hips, and again, home health was considerably lower than any other type of spend. And then on an episodic basis, same held true. Again, this was commissioned by an Alliance for Home Health Quality and Innovation, but the data supports the appropriate setting of care. And that becomes a big part of post-acute, which we'll talk about next. So in what we tried to do here is kind of like align the discussion around potential post-acute savings opportunities, but there are huge challenges that are facing post-acute spend. So how do we begin to look at those challenges as we move forward? So I just wanted to kind of list some of these out and give some hypothesis as to why these are happening. So post-acute services are in independent silos today with little integration across settings of care. I'd say that's generally true throughout the country. The place where it's changing dramatically is in hospital-based systems, and in particular hospital-based systems that are also payers. They're exploring and they're understanding how to manage and integrate across silos to kind of get rid of the silo nature of the models. In these models, nursing homes, LTACs, IRFs, and home health, they historically have been fee-for-service, independent structures, and reimbursement has been tied to visits and creating utilization, and changing that becomes a really big shift in consciousness and business model for those organizations left to their own devices. If they're part of a structured organization like a hospital system, they begin to now think about how they can utilize the resources internally to make them more efficient. So the second issue is that there's a preponderance of fee-for-volume reimbursement through the post-acute world, and there's a lack of risk-sharing models that are in play today. More and more activity is in this area, both in nursing homes and in home health, and you can find it in nursing homes actually moving to control the overall spend for their population through the rise of special needs plans and institutional SNPs, and that are owned by the entities themselves, and in home health playing a bigger role in conjunction with health plans to focus on issues like readmission and getting rewarded based on the results of their interventions. There's no clear guidelines on which setting is the most appropriate for an individual's patient's condition. So the discharge process and the way that works post-discharge from hospital, there's a lot of factors that come into consideration as to why one goes to a particular facility and how that works in the overall structure of things. So we're going to address this in a little bit from a strategic perspective and how one can wrestle with that and come to a more a conclusion that is more optimal. A big challenge here is also the interoperability problems in acute and post-acute and trying to coordinate everybody together, which has been pretty dramatic and pretty challenging for even within the same institutions. So when you look at the entirety of this picture, MedPAC would also argue that there's a regional Medicare variability, that post-acute represents a large percentage of the overall challenge to Medicare spend. So we took a look at that world and the challenges that health plans and integrated delivery systems and ACOs and and bundled payment programs are facing by maybe not most effectively managing post-acute spend, and how would we develop a model that could address the challenges that I've just talked about. So if you look at this slide, we're on slide 12 here, that, I would know that I'm controlling this, I guess. So we looked at a new accountable PAC partnership model to meet the demands of a value-based care marketplace. And what does that look like? So if you start on the right, where, like around 1 o'clock here, the health plan provider partnerships with shared risk. So we think it's really, really critical that the discussion emerges and evolves with the providers of post-acute services to be focused on two aspects of payment methodology. One, along risk-sharing models. So if you're participating in a bundle and your providers are being paid fee-for-service, there might not necessarily be an alignment of interest. So we're actively discussing with our providers and with plans how you shape a bundled payment program or a full or partial capitation program or a shared risk program on a general basis with the overall provider system and how you make it work better. So this is a huge part of the equation, because if you can't align the financial interest, it's going to be hard to align the clinical and business interest. So from there to how do you go about the process of determining who do you want to contract with, even if it's within the same system? Who is the best home care provider? Who's the best nursing home provider based on conditions in your geography? And that's the kind of thinking that needs to take place to make these strategies, we believe, work. So state-of-the-art analytics and a technology platform needs to be incorporated into any of these system approaches and strategies. We have developed a state-of-the-art methodology and approach on post-acute analytics that is tied to machine learning and artificial intelligence, and enables us to do predictive modeling as well as identification of risk, transition management, and who's the best provider for the particular circumstance that a patient is being discharged for, that you're responsible for. And we'll go through that in a little bit to give you a sense of how that works. And then if you go to the bottom left, site of care and network optimization, this becomes a very, very significant factor moving forward in this whole discussion about post-acute resources and service delivery. One would argue that a nursing home is not just a nursing home, is not just a nursing home, and just getting a contract with that nursing home may not solve your problem in a complex post-acute world, or same with home health. So it requires one to analyze their local geographies by conditions and by determining which providers are the best providers per the condition, and do you align their interest, as in the right, on the top right column, so that you have them performing in the highest license category they can perform under, and then you can track the quality and the cost performance in a way that optimizes care on a quality and cost basis for the patient and for the payer, or if you're the payer. And the last piece moves to the integrated home, the model that we have evolved, that we're talking a lot about now, is the idea of eliminating these silos by having what we call Home Star, which is a clinical intervention strategy using RNs, physical therapists, social workers, etc. And they're basically managing a patient through an episode of care, which I'm going to show you in a little bit how that strategically works, and then transitions people from the appropriate place of care to the home sooner, faster, quicker. So in the next slide, we begin to look at what that looks like. How can you actively, we all talk about how we coordinate care and how that we manage patients through an episode of care, but in post-acute it gets really tricky because of the factors we've discussed so far. But in this model, we're looking at managing somebody across the entire post-acute continuum, starting with the pre-admission assessment. So an eligibility and benefit verification process has to be in place so we know we're taking care of the right person who's got covered benefits at the right time, that we're assessing from a surgical perspective what they're having done and what's going to happen as a result of that post-discharge, and factoring in a home safety assessment, which becomes really critical in the scheme of things, because if they're eventually getting home and they had an episode around joint replacement, you want to make sure that somebody goes to that home and sees if there are throw rugs all over or there are grab bars in the shower already, so that the patient is ready to maximize and optimize the care setting, if that's home, when they get there. So moving from there to the hospital discharge, process requires that there be an on-site nurse working with the hospital staff to coordinate the discharge and to determine the most appropriate setting before the discharge actually occurs, and to make sure that if it's a facility setting, that the facility is aware of the patient and aware of the presenting diagnosis and the condition, and there's a protocol in place for treating that person. And then we move to how do we determine which of those facilities makes the most sense and is the one to discharge on the individual. So we look at things like rankings by disease and by quality and by cost, and aggregate all of that information and come up with a conclusion, and then choose that provider should be in the network already, but now we're trying to get even more specific by managing the patient to the right setting and then collaborating with the provider after the patient's actually there, so that it's an ongoing process. A challenge in post-acute has been, like all other settings, when you transition from one to the next, the interoperability of the technology platforms. So the nursing home doesn't really speak to the home health agency, doesn't speak to the family, doesn't speak to the primary care physician. And that tends to create a communication gap that can lead to problems down the road. So we're going to address that as well. And the goal here is to get to a place where the patient is functioning on their own, the transition to a safe environment and healing in that environment, and ideally we view that as home, and that they're supplementing the home activities with things like community-based resources and integrating with those community resources, whether that be Meals on Wheels or whether that be a transportation system. We're very aware of these LTSS services in Medicaid now, but not to think that that's not applicable for all populations. I'm going to get to some of your questions, okay, in a second. I'm getting a couple of these questions, but I'd like to get to a couple more points, okay? So keep those coming in, and I'm going to keep going here. So the next talks about how you move from the diagnosis to the actual encounter in the hospital through the discharge. So the focus is on what's the appropriate site and path of care for each patient tied to their condition. The key component, again, is state-of-the-art analytics, machine learning, artificial intelligence, which gives you the ability to select the best provider in this high-performing network tied to each member's specific condition and needs. So in this joint replacement patient going to the hospital, and then upon discharge, looking at factors like in provider A, the red line is bad, the blue line is good, the thicker the line, the more volume. So in this case, it's important to remember that because that's going to come up in the next couple of slides. The red line shows that this provider, in terms of major joint replacement, which this patient had a procedure done, they have high readmissions and they have high volume. So they're a high volume shop, could be a home health agency, could be a nursing home, could be an LTAC, but the result is they're producing high readmissions. So they're putting people in, getting people out, and they're not really managing anybody through the episode of care to reduce that readmissions. In the second provider B here, you can see that here's a high volume agency, but they have a low readmission rate, and high volume means they have the resources typically to take care of the patient, and their ability to keep that patient out of the hospital for readmission is pretty strong there. So that's pretty good indicator that they're the right referral source for this particular patient. And in C there, the third case would be a low readmission and low volume. So they might not have a lot of experience, and they might not have necessarily the right providers, but they can manage a patient at home or in a setting to avoid a readmission. So they're somewhere in between. But the idea of a customized care plan begins with, again, finding the post-acute provider that excels depending on the needs of the individual patient. So this is not to get to the point where we're at total individualized care plans, but it's kind of moving directionally that way, as you'll see from the strategy. So from a financial perspective, to get the alignment of your network providers here, it becomes pretty important that we talk about financial models other than fee-for-service, because fee-for-service rarely aligns the incentives of all players and becomes a volume game as opposed to a value game, and is kind of really not where the ball has moved over the last couple of years, and it's probably directionally the place it needs to be moving. So what are the payment mechanisms that we're seeing here? They're things you all know about: shared savings and shared risk. Could be upside only, could be both. But the idea that there's a fee for the service provided and then there's an upside tied to it becomes a pretty good incentive. A bundled payment where there's one payment and you're part of that system is another good methodology, because we know that bundles are working really well on a general basis. So the idea of being a bundle payment player, either as part of or for the whole episode of care, becomes a dynamic. A partial capitation approach could be a road towards full capitation, or it could be a capitation for a select set of services that you're more comfortable with and the health plan is willing to work with, or the government in a bundled program or another type of program. Full capitation, ultimately assuming full risk on a prepaid per member per month basis. So all kinds of models for a post-acute foundation of payment make sense. And then looking strategically at what are some of the performance targets or indicators that we should be thinking about in terms of building into the incentive with a payer as a provider or as a payer to a provider. So I would want them to be focused on readmission reduction, because we see the scope and size of how big that issue is in post-acute care. We want them to focus on post-acute savings through appropriate care transitions management. So not just to send somebody to a facility because that's the way it's always been, but thinking logically through and developing and creating a system that makes sense and is quality driven and efficient makes the most sense. Driving patient satisfaction makes a lot of sense and is an indicator for payers in terms of quality rankings and a variety of issues, right? And guaranteeing savings. So the ability to, if you're a home care company or a nursing home company and you want to enter into one of these type of arrangements with a payer, you might want to focus on the right box or the left box, but the right box is kind of what's got to be core to your value proposition to move this forward. Okay, and then we looked at how do you focus on a care transition, reducing readmission strategy, and what are the critical components. Pretty logical by now, hopefully, that there's strategies in your head starting to emerge that make sense. But again, we've thought about this for quite a long time and have the data supported now. So starting with patient identification and identifying the risk at admission via the patient census, having an algorithm to identify high-risk patients in place, and receive post-discharge information to identify risks associated with that discharge. So all of that is factored into consideration when making referrals and following a patient through a 90-day episode, if that's what you're being measured on or you're utilizing. In terms of engagement, proactive outreach, which is not spelled right there, homebound requirement waived. In home health is an example. There's a homebound requirement that the person would have to be homebound, and the ability to get that waived, same as 3-day nursing home stay for ACOs, being able to waive that so somebody can go directly to a nursing home as opposed to having a hospitalization first. So the waiver strategy is really important to maximizing the ability of post-acute providers to excel and perform at the top of their licensure. The nurse telephonic outreach to identify gaps, critical because you don't want events happening in an environment that could be at home or could be in a facility, but that it's not being managed and it's not being coordinated. And then the ability to drop a nurse into a environment to manage a crisis before it exacerbates into a major crisis. So in our strategy, that means we can have one of our telephonic nurses coordinate collaboratively with one of our high-performing agencies in the home health world and deliver a nurse to go in to a home in a short turnaround time to deal with any potential crisis. And then moving to the last piece of this is the consultation in doing the patient in-home assessments and coordinating individualized care plans and make that a consistent process so that we're not having exceptions all the time, that we're at least trying to manage by a consistent pattern and process. And that from a coordination standpoint, that there's a collaborative approach with the patient's care team and caregiver and physician and home nurse and any other clinicians involved. The pharmacy or the PBM is involved in medication reconciliation, and medication therapy management is part of a process. Local community resources are engaged, and the health plan has resources, if it's a health plan member, that are also engaged so that they're moving the person through the process. So here is an example of utilizing the data in the analytics programs that I've talked about before. We call the platform that this all operates under HomeBridge. And in HomeBridge, we're able to take a look at the entirety of an episode, document every step of that episode in a centralized medical record that can foster communication between the physician components as well as the facilities, as well as the case managers, and all elements of the delivery system are this one central place where all of this is documented and there. And it also incorporates the ability to use the machine-based analytics that drive decisions. So here's an example of a patient with a DRG code that would be related to a coronary bypass or related event, and that the bluer the line, the better in terms of readmissions, and we're benchmarking against national benchmarks. And the thickness shows how many patients were sent to a given, in this case, home health agency from the hospital. What's insightful here is that the impact of your post-acute destination on outcomes. So you're really looking for the best possible provider in your geography to manage the patient episode, again, at the top of their license, coordinated with your care management and with the physician component so that you're getting clinical efficacy and you're having all of the data that one needs to manage somebody in the most efficient way and avoid unnecessary things like readmissions and services that wouldn't be necessary to get. And our goal is to get them home in a secure environment sooner, faster, quicker, if you will. So this is one example of using that. Another example of using intelligent analytics is to forecast the probability of a readmission and to guide appropriate care transitions. So in this case, this made-up person, James Smith, in this made-up world that James lives in here, is it's a patient like me analysis. So in this case, we have 272 patients that had a similar diagnosis and a similar procedure as James did, and we analyzed from a variety of factors: age, geography, zip code, services in that community, shopping patterns, etc., to come up with a predictive model that would say, this is the likelihood of readmission at 81% here. this is the likely cost of that readmission, and here's the likely window of time for that readmission, and the likely reasons have to do with falls, syncope, and pain. So there's a structure behind the methodology, and that working in conjunction with a clinical team and a nurse team, able to choose the right provider in the right transition so that James here is well taken care of, and all of his discharge options are in place, and questions are mounting. So we're going to almost be done here, and then I'll go to questions. So the referral. So now we look at also how do we use this analysis to be able to focus on quality scores and identifying the best provider for the patient-specific condition. So in this case, we're looking. This is not an eye chart, but I know you're laughing when I say that, but it's kind of looking at a provider on the right, the little yellow provider, Allied Health Services, and staying with the same methodology that the redder the worse and the bluer the better, the thicker the line, the more volume. And this is focused on a discharge to get somebody home sooner, quicker, to the best provider, which is a home provider in this case, and the shortest path to get there, using predictive modeling guides, getting the patient to where they need to sooner, quicker, faster. Now, sometimes it would make sense for the patient not to go home right away because they might not have additional support, or the community norm might be they can have a short-term stay in a rehab or nursing home situation, and that short-term stay maybe accelerates rehab. So instead of having rehab once a day, maybe they're having it 2 or 3 times a day. So they're maximizing their time in the facility to get home sooner, faster, quicker, and then the transition to home being congruent and consistent with the entire strategy. But at least you know in this methodology who to go, who's the best provider, and how you want to get to them, and then what your expectation is. And if you go back to the alignment strategy of focused on what the payment methodology should be and aligning the interests, now we're all working collaboratively. And if you have a technology platform like we refer to Homebridge here, then you kind of put the whole thing together into a systemized approach towards post-acute care management. So in this last piece here is referring to reporting quality metrics and key indicators in quality that can be positively impacted by the model. So we've talked about readmissions, and here's the initiative and strategy around that. We talked about medication therapy management and the ability to do that by having access to the home or the nursing home or wherever they are to mitigate against risk of falling, which, again, like the other two, are measures of STARS ratings and quality in health plans or in home care or nursing homes, and then having an intervention strategy around that, and same with medication reconciliation and preventable complications from hospitalizations. So all initiatives that can be managed in a post-acute environment. So some of our results in 90-day episodes for a commercial client all-cause readmission program here, reduction from 14.5% in a 90-day stay to 8.8%. In a 30-day readmission episode, reduction from 9.6 to 5.8. Overall, 95% of the patients are satisfied with the program when recommended to a friend, which is, as you know, a key indicator in measuring patient satisfaction. And then we have two Medicare examples of a statewide health plan and a multi-state blue plan and a population in a single state. And this was just on a 30-day readmission reduction, but these are actual and doable and can be more manageable. And in closing this out, there are legislative and regulatory changes that are pushing the PAC industry into a value-based world. And I would just alert you to, I'm sure you all know, H.R. 4994, which is the IMPACT Act, is moving post-acute reimbursement towards condition-based payment, working out the methodologies through MedPAC and CMS, but it is statutory. It was passed by a bipartisan Congress and signed by the President. PAC providers are moving to scale, so you're seeing a lot of merger and acquisition activity in the space. And I would argue that it has to be intelligently driven as opposed just to be driven for the sake of acquisition here, because you need to understand that healthcare is always local, right? And by being local, that even if the same entity owns a home health agency or a nursing home in Geography 1, it may not operate for a variety of reasons the same way in Geography 3 or 4. It may have the same policies and procedures, but due to a variety of issues like workforce and state laws, there may be different nuances that kind of make that different. So just bringing that into a mindful way of making us think about that a little bit before acquisition for the sake of acquisition. Data and support system based on predictive modeling. You know obviously how I feel about this issue, and that the ability to utilize big data to create high-performing networks and partnerships that move towards the right result are critical, and having the administrative skills and financial resources to manage risk, not for the light of heart and not to be taken for granted. So that's what I have to do, what I have to say, and happy to go to the questions now.
All right, thank you.
Okay.
We're going to address some questions that came in during the presentation. And as a reminder, to ask a question via the web presentation, please choose the chat pod located in the lower left corner of your screen, type your question, and hit the send a message button. Our first question comes from Nirav, and I believe this had to do with the material on slide 10. Are these numbers adjusted for case complexity?
And this had to do with the early slides, I believe?
I believe so, with slide 10.
Yeah, I don't have that in front of me, but I believe the answer to that question is yes, because from an actuarial standpoint, we kind of went condition. Our data is adjusted by condition. So I would think that case complexity is a factor into that. So if you want to contact me at AHIP, I can get you more specific information on that, but I believe the answer is yes.
Great, thank you. Our next question comes from Sandra. How do you provide consistent transition strategies?
By having one, first of all, and by using our data machine that allows us to be predictive in what is the right path. What I wasn't able to show, because I believe I'm showing it at AHIP, would be a path of care based on a condition and why somebody might go to a nursing home in Geography Y, but in Geography Z may go directly to home, and what might be the strategy in getting there, and what are the issues beyond just, what are the outlier issues that might not say that everybody can have one path home based on a condition. So I think Sandra, if you go to our session at AHIP, I'll have more detail and be showing that model.
Our next question is from Adam. How often are your teams leveraging community resources and engaging them, since services available can vary widely by geographic region?
Couldn't agree with you more, Adam, and this is a big deal. It's being documented, and being part of how you do business in Medicaid, as you well know. But the challenge is that because the Medicaid system is kind of driving people towards more effective utilization of home and community-based services, it makes good business sense for health plans to be thinking about these services as well. And I would argue that environments like nursing homes and assisted living facilities and inpatient rehab facilities all have some characteristics that lend themselves to these models of home and community-based service delivery. They make meals in their facilities and they have transportation systems typically. So one might argue that they can drive meals to homes, and they can drive people to appointments, and they can coordinate social services tied to particular conditions. So very, very big part of post-acute, building towards independence, that this has to be built into the models.
Sandra is asking, how did you get to the DRG during the hospital stay?
Because we knew that before the patient entered the hospital. We knew the DRG that they were being admitted for, and we were part of the process from the beginning. It's really difficult to do this after the fact, Sandra, and our sense is that our clients should give us easy, quick access with their own care coordinators, and that partnership should be formed in a way that allows us to know and anticipate what's going to happen, as I showed in one of the slides, even before the surgery or the procedure happens in the inpatient setting, so that we can have a map of where that person goes from step by step by step through the process.
Adam is asking, what role does data from physician review websites like HealthGrades play in finding the right provider for the right patient?
Not that particular website, but multiple websites and multiple data sources are built into our Homebridge platform to drive our decisions, and its basis is 100 million discharges from hospital settings and nursing home settings and home health settings, and then aggregated with a variety of physician-related public data and MDS data and OASIS data, along with things like Walmart shopping data and zip code-driven data, and all of that built together into a process that yields information that drives decisions in the methodology I've laid out here. Could happily talk about this with you more at our AHIP session, because this is a challenge to just give quick 1-minute time slots to on the phone. So happy to talk to you more about this later.
All right, our next question is from Michelle. She says, concern with scalability of quality providers. What happens to quality when they double their volume?
So this is a real challenge, and it may mean that if what happens to quality when you double the volume might mean you have to go to another facility, or you have to help the initial network provider that's your partner in this whole process deal with this by helping them identify additional resources or strategically having a more balanced approach in the way that they're recruiting or that they're building out. I wouldn't rely on one provider in one geography. What our mapping allows you to do is select like the top 5 providers by condition and then drive volume to them and then track them, trace what's going on a daily basis through the Homebridge platform and modify accordingly. So we're pretty much on top of them on a regular basis. And our deal, like a health plan's deal, should be to collaborate with partners to achieve the desired result. And if one's not doing it, then we need more. And if possible, work with existing partners to come up with strategies to help them do better at what they do.
Great. Next question is from Daniela. What are your most important capabilities that drive truly differentiated clinical practice performance in post-acute? Which of those capabilities are payer-like versus provider-like, network contracting, SNF, utilization management, risk stratification, predictive modeling of care?
So Daniela, your question in terms of my ability to read it is at the end of the thing here, and I'm not beginning able to see the whole thing. Oh, now I can, I think, more. So the point here is that in certain cases, we're delegated by the health plan to actually assume the entire network function, if you will, and that might be managing the entirety of home care or post-acute care and contracting with the network, or it may be using their existing network. And honestly, that depends on the dynamics and the conditions in that local environment. In terms of clinical integration, the fact that we have a platform that has interoperability with other platforms would allow us to be a great add-on clinically to our client, and we use that today in terms of risk stratification and predictive modeling and really care transitions, because a case manager that's doing care transitions, and not trying to be too provocative here, or that hasn't really spent time in this post-acute area is going to be challenged to execute on what I've laid out here as a fundamental strategy, right? It's not going to be easy to do. So I'm suggesting that this is a cooperative, collaborative approach, that we have a lot of the resources in place and others are going to, but we have to have partners to make it work effectively. So there's another question that just came. Oh, I don't know. You have to look in the book on the AHIP session. Aside from nursing services, are you familiar with any innovative partnerships using other community-based services to conduct the in-home assessment of care transition coordination? Yeah, there are companies that just do in-home assessments. There are platforms that do, care transition strategies and outsourced care coordination. But from my way of thinking, having been in the industry quite a long time and having run plans and operated plans, I have to realize in the world today what my health plan's limitations are and how many vendors can I actually deal with and how do I manage my business and what's my approach and strategy to that, because it's much more difficult now than it was when I started out. I can tell you that in terms of things you've got to be keeping your eye on the ball on and managing. Post-acute being one of the more challenging because because of the cost implications coming out of the box. And I'm in managing care. I'm also a home health guy I'm on the board of the Visiting Nurse Association of America, and I used to own a home health agency. And the challenges of managing very sick patients in their home the technology is catching up with the ability to change the home into a more hospital-like setting, but I don't think we're 100% there yet. We're on the way to getting there through telehealth and telemetry in general, what we can do now. But more to come, and we'll talk more at AHIP.
All right. Thank you very much for that great presentation. Just to note, ladies and gentlemen, Gary is referring to the AHIP Medicaid Medicare Conference in Washington, D.C. from October 23rd to 27th. Thank you again to the audience for participating in today's conference. Thank you to Gary. That concludes this webinar. Thank you, and enjoy the rest of your day.